Spend a few minutes on introductions, and then we're going to be speaking with you about our breast health consults that are part of the Wisdom Study. If you're enrolled in the study, we'll tell you all about what's involved and why we wanted to introduce you all to these consults today. So we want to hear from you. The format for these forums, if you've attended these before, then you know that it's really a meeting style. We don't want it to be too like didactic. We want this to be interactive. Put your questions if you have them in the chat. We probably will we might collate them until the end if there's a lot of questions, but we'll see what we can answer in real time. Just you can also raise your hand to speak up if you have a question that you want answered right then. But we do ask that you mute yourself if you have stuff going on in the background. And the meetings are always recorded and then shared on our YouTube channel. Anyone can go and look at any of the community forums that we've done in the past. And then a short pop-up window will come up on your computer toward the end of the meeting, and it'll ask you a little survey about what you'd like to learn about in the future. And we love your feedback. See, also the mission of these forums is to move together toward equity and better health outcomes in the breast cancer space for everyone. So these forums were created as a way to really build a sense of community around the wisdom study and the study's mission to improve outcomes for all women. What we've discussed in prior forums, we've had a lot of them now. We've been doing them for the past few years. I won't read through this long list, but you can kind of see some highlights. I'm just going to call this out that we have done a few forums specifically around lifestyle habits that people can make changes for themselves around with regard to breast cancer prevention. And those include things like the impact of alcohol on breast cancer risk and nutrition and fiber on gut health and breast cancer risk. And I think we've done one on, yeah, that's the one: diet, nutrition, alcohol, and exercise. So we have done some forums in the past around risk reducing strategies, which is, we're going to hit on that today too. So today's discussion is going to be presented by Wisdom's breast health specialists, and they're going to tell us about the consults, these one-on-one consultations that they do directly with women who are in the Wisdom study who are identified as having elevated risk. So we're going to hear from Dr. Deborah Goodman-Gruen, who is one of our breast health specialists. She has a PhD in epidemiology from UCLA, and she also has a master's degree in public health from UCLA and an MD. So we're very lucky to have these two people as part of our team. We're also going to hear from Miss Kathy Ross. I think, there's Kathy's slide. Kathy helped establish the Cancer Genetics Clinic at the Vidant Center, and she has a position at UCSF Health's Cancer Genetics Prevention Program and research role in the Wisdom Study. And she has an MS in genetic counseling from Indiana State University. So thank you so much, Kathy and Deborah. Let me know, would you like me to continue sharing my screen, or should I give you the presenters right so you can share your screen and then go through your slides at your whatever cadence you want to go through?
I'm okay sharing your screen. I don't have pulled up the slides.
Okay. So you'll just tell me when to move to the next slide?
Yeah.
Okay, great.
Right. So, for, I think,
Kathy, were you going to kick off these?
yeah, I was. I'm going to actually just share if you don't mind, because then I can kind of go through the quick introduction for everything. Um,
Sure. So should I stop sharing my screen?
that should work. Yeah,
Okay.
that's
Okay, great. Now you have your
there
screen
we go.
share. Perfect.
Okay. All right. So our goal for today is to just try and go through what these breast and chest health consultations are and sort of the typical content of what we go over and why, if you've been on the fence about scheduling a consultation or have concerns about your um, risks, to know a little bit more about what we can try and review during those consults and go through a couple examples and walk through the different risk factors that we think about and discuss with participants during these consults and review just the sort of high level screening recommendations or risk reducing strategies that some of you have already attended forums on that we can get into much more detail and specifics, but sort of just give a little bit of the high level overview of what we talk about and um, discuss the breast health decisions tool and some of the tools we use to with participants to uh, evaluate and make decisions about their breast screening and breast health, and also include some of the genetics perspective and how hereditary risk factors like familial mutations or pathogenic variants can alter how we think about all those different risks. And then try and any questions that we have along the way that we can't get to in that moment to try and leave plenty of time at the end to go through them. So that's sort of our hope with today. There's been lots of different breast health specialists over the years, besides just the two of us that are on the call today. There are many others, many of you have met with previously. I know I saw in the chat some of you all have been with us for 5 or more years, so thank you. It continues to evolve, but in general, they've always been someone with clinical training or background in breast cancer, breast research, and genetic counseling. Sort of the split and coverage for both. And then there's the purpose of these consults is to try and go through these different risk factors with those that are at highest risk to develop breast cancers, those who have known hereditary risk factors where we may have additional changes to their screening, and try and make sure that both populations, those who are at high risk and those who have high risk due to their genetics, are aware of their risk factors and are informed about how those different risk estimates can impact their care and what recommendations we're making as part of the study, and to provide another opportunity to connect about what they can do about that and verify the risk factors, make sure that we're working with the most current up-to-date medical information for you and that we're using the right information in our risk calculations, and also ensuring that we're using those risk factors for your specific screening recommendations correctly and sort of adjusting based off of that. And as the genetic counselor for the breast health consults, I always have to sort of add this additional caveat that for anybody, even if people have no mutations identified, nothing in their genetic code that we see that is a clear explanation for being at a higher risk for breast cancer or other cancers, that can happen for a wide variety of reasons. And wisdom is using only the level of information that we know at this time. So there may be other loved ones who may still benefit from doing their own risk assessment that are not participating in wisdom or are, may have their own history that doesn't have an explanation. So we encourage all of you to share your results with your family and to allow them and their providers to make the most informed risk assessment with the best information available for all family, because it's entirely possible that there can be explanation for a cancer history that by simple random chance, some people may not have been inherited. So it's something we tend to have more in-depth conversations during consultations with participants about what that might mean and how families can still best consider and adjust according to the history and risks that they have. But we try and go into that with all participants. And as part of those consultations, participants get their test results, their breast health decisions tool, if it's available for them as part of their ARM, and a consult summary as well as screening assignment letter that they can take to their providers to help make sure that everything we go over and discuss is available to their provider, that they can discuss it at the next follow-up appointment or other care with their local team that's outside of the study. And Deborah will be talking about sort of what all of those tools are and what this information is. There's a great resource, and I've linked to a couple of other website links and resources that the Wisdom Study has put together over the years about what different educational tools have been developed or shared as part of these consults on this link here. But there's other tools and specific risk factors and information that she gets into in a lot more detail with our participants. So.
Okay. I will try to share my screen. This might make it easier for you, Stephanie.
Okay.
You're going to try to share it?
Yeah, it's just weird when I do this. Sometimes it doesn't pop up quite right. All right, does everyone see that? Did it work?
Yes.
Okay, perfect. All right, so thank you for having me. I'm excited to talk about the breast health decisions tool with everybody. On kind of a global level, the purpose of the breast health decisions tool is to show participants their personalized risk calculation, how we do that calculation, all the components that go into calculating your personalized 5-year risk. We then give like a practical interpretation of that number, show the comparison of the participants' risk with the average risk, and then show how we put them into our different risk categories and screening categories. And then we end with going through some risk strategy, reduction strategies. So I'm going to do that with a participant that we have to kind of show you how we do this. So overall, we take all the information that participants give to us to calculate the 5-year risk of breast cancer. So we use the questionnaire information, we use information from the saliva sample, and we use information from the mammogram. And when the way we use that information is to calculate this number here, this personalized 5-year risk of breast cancer. We then take the participant's 5-year risk of breast cancer and compare it to the average risk of breast cancer in someone their same age and race. And we make that comparison, we then can group people into one of 3 categories: average, moderate, or high risk. And based on that risk calculation or that risk bucket, we then can assign a screening or make a screening recommendation so that people who are at the lowest levels of risk are getting less screening than people at the highest levels of risk, and several categories in between those two. So in order to calculate this personalized 5-year risk of breast cancer, we combine 2 major categories of information. The first category is a breast cancer risk model. The model that we have chosen to use for the Wisdom Study is called the BCSC model, which stands for Breast Cancer Surveillance Consortium model. It's very well validated. It's been validated in over 1 million women. And these are the 9 variables that are included in the BCSC model. So we use age, race, ethnicity, family history of breast cancer in a first and second, we need to add that word there, first and second degree relative, whether someone has had a breast biopsy, and if so, the cell type, if that is known from that biopsy, the breast density, which is the information we get from the mammogram, menopausal status, body mass index, and we're including an additional line in there that you don't see, but it's there, which is if someone's had a child, age that that first oldest child was born. So just for example, this participant is 54 years old. She's white. She has, I believe her mother had breast cancer diagnosed at age 54. She has had a previous breast biopsy, and this was the cell type from that biopsy, atypical ductal hyperplasia. She has extremely dense breasts, and during the consultation, we go into kind of what exactly that means in terms of how that is decided from the mammogram and the implications of that. This woman is premenopausal. Her body mass index is 23, and she had one child when she was 36 years old. So those are the components of the BCSC model. The second component that we use to calculate that personalized 5-year risk is information from that saliva sample. So we do two things with that saliva sample. The first thing we do is we look for BRCA1, BRCA2, and several other genetic mutations that are associated with a moderate or a high risk of breast cancer. This participant was negative for all those mutations. The second thing we do with that sample is we calculate something called polygenic risk. This is a newer genetic a newer type of risk that has been identified in genetics, and let me show you a picture here. Okay, so here's our little picture of DNA. And obviously I go into a lot more detail and explanation, so I'm sorry if this is very abbreviated during this, but if someone does go through a consultation, we spend a lot of time talking and explaining the structure of DNA. But this is our picture of DNA here. This string of letters is a very small sample, and each letter represents a single nucleotide in DNA, which is the basic building block of DNA. And if you focus on this area that is in bold here, in 95% of people, there are those three nucleotides in that location, a C, an A, and a T. During reproduction, it's possible that there can be typos. In this case, the C has been replaced with a G. That is called a single nucleotide polymorphism, which is abbreviated as a SNP. There are a lot of SNPs that happen. Most of them don't seem to impact our health in any way. There are, however, several hundred SNPs that have been shown to be associated with very small changes in breast cancer risk. Some of these SNPs actually have been shown to be somewhat protective and can reduce the risk of breast cancer. Others are neutral. Others have been shown to increase the risk of breast cancer. The contribution of any individual SNP is extremely small, fractions of a percent. But there are several hundred there. And so we use that saliva sample to look for any of those SNPs. And then they are added together for a total score. That score is what is the polygenic risk score, the sum of any of these potential SNPs that do impact breast cancer risk.
And I do want to check in. I think there's a couple of hands raised. I don't know if folks want to put questions in the chat. I can start aggregating those.
Awesome. Okay, so this slide shows the interpretation of polygenic risk. This is created by taking a population, figuring out everybody's polygenic risk score, and then lining them up, those with the lowest polygenic risk scores here on the far left, those with the highest polygenic risk scores on the far right. And when you do that, you get this type of distribution in a population of polygenic risk scores. So when you look at this graph, you can see the majority of people fall into this central gray area. The peak of that is defined as 1. So if somebody has a polygenic risk score of 1 or close to 1, we would say that they have no contribution to their breast cancer risk from their polygenic risk scores. Because some of these can be somewhat protective, it is possible to have a polygenic risk score less than 1. That would be down here in this bluish area. These people are getting some risk reduction from their polygenic risk score. Conversely, a polygenic risk score greater than 1 over here in this pinkish area means that there is some contribution to risk from their collective SNPs or their polygenic risk score. Okay. So in this case, this participant had a BCSC score of 6.86. Her polygenic risk score was about 3.3. So when we combine these to get her total 5-year risk, she had a 5-year risk of breast cancer about 19%. Okay. I will show you what that means on a practical level here. So, sorry about that. Hold on. Okay. So if you focus first on this left-hand group of figures, that is meant to represent 100 people exactly like this participant in every way, kind of 100 clones of her. If you were to follow that group of people for the next 5 years, on average, 19 people in that group of 100 would go on to develop breast cancer, 81 would not. On the right is the comparison group. This is a group of 100 average 54-year-old white women. That risk in that same 5-year time period is about 5. So 5 people in that group would go on to develop breast cancer, 95 would not. Okay. People in this group on the right, the wisdom study would recommend, those are the average risk people, we would recommend that they have a mammogram every other year. Our recommendation for people at average risk is to begin screening at age 50 and to have a mammogram on alternating years. This woman is in our elevated risk group. You could see her risk is much higher. This was 1% compared to 19%. She is in our elevated risk group. Our screening recommendation for her would be an annual mammogram. In addition, we would recommend an annual breast MRI. Those two things ideally would be spread out by 6 months. So every 6 months, she's alternating between a mammogram and a breast MRI. Okay. That is the 5-year risk, and 5-year risk is what we use to make our screening recommendations. This data can be looked at in the exact same way, and instead of following a group of people like her for 5 years, you can follow them for 10 years. And obviously, with twice as much time, there's twice as much opportunity. So the numbers pretty much double. Her 10-year risk does go up to 35% compared to 3% for the average person her same age and race. And her lifetime risk goes up to over 46%, compared to 8% for the average person her same age and race. This shows all the different screening recommendations that we have in the wisdom study for our participants, depending on their 5-year risk calculation. One thing I neglected to say at the very beginning was that this breast health decisions tool is specifically designed, and the people that I speak to do not have a genetic mutation, and Kathy will go over what happens if someone does have a genetic mutation shortly. So as I mentioned, no screening is for people at average risk under 50, and then at every 2 years is when those people do turn 50 and are still at average risk. Every year is for moderate risk. Our higher risk group, like the example that we had, is called the 6-month group. Those are the people that are alternating between breast MRIs and mammograms. Certain age refers to people who are under 50, but we're watching their risk. And if their risk hits the age of an average 50-year-old prior to their chronologic age of 50, we would recommend they start screening. And then this stop screen group are for people who are at low risk in their 70s who reach that very low threshold. And then we recommend that we don't feel that the benefits of screening outweigh any harms. So the primary objective of the wisdom study is to stratify screening based on personalized risk and to find that spot where the benefits of screening do not outweigh the harms of screening, to find that tipping point and introduce screening at that point and the modality of screening at that point. Okay. So that pretty much covers the first component of the breast health decisions tool, which deals with screening. And screening is hugely important. Screening is getting at early detection, and that is extremely important in breast cancer screening or in breast cancer in the field of breast cancer. Equally important, however, is secondary importance is secondary screening. And so we do spend some time talking about the different risk-reducing strategies. So risk-reducing strategies are grouped into 2 categories. First category are lifestyle factors. The lifestyle factors that we do talk about are alcohol consumption, body mass index, physical activity, smoking, and hormone therapy. We spent a lot of time personalizing this and going through each of these in terms of the mechanisms and how specifically it impacts the participants' life and well-being. Lately, hormone therapy has been a big subject, so we're always available to talk about that on the consultation as well. It could take the rest of our talk if I got into that now. The second category of risk-reducing strategies are medications, and this is a subject that is really important to talk about. It's very similar to the concept of taking a statin. If somebody has high lipids and it reduces that statin reduces their risk of heart disease by lowering their cholesterol. Similarly, there are 4 medications that are available and recommended for women who are at moderate or high risk of breast cancer. These medications reduce the risk of breast cancer by up to 50%. You only need to take the medication for 5 years, and that 50% reduction in risk continues even after the medication is discontinued after that 5-year period. The reason for the color coding here is because some are available if someone is, tamoxifen is the only one that is available for participants who are premenopausal. All of these medications are available for someone who is postmenopausal. So in this case, we have a green check mark here for this participant because she is premenopausal, and of these medications, only tamoxifen would be available for her. So we spend quite a bit of time talking about how these medications reduce the risk of breast cancer, which ones may be best for the participant based on their medical history, other medications that they take. So we personalize this as well and give our recommendations. And lastly, we take these risk-reducing strategies and personalize it and show the impact of each of them on that lifetime risk. So, for example, with this participant, we calculated her lifetime risk to be 46%. You can see that she doesn't smoke. That's not negatively impacting her risk. She has a very low alcohol consumption, so her numbers are not impacting by that. Or she has a good BMI. If she does get the recommended amount of physical activity, that is bringing her risk down from 46% to 40%. And if she does decide to take that tamoxifen for 5 years, that by itself can bring her 46% lifetime risk down to 23%. So if she is able to combine, for example, the exercise and the tamoxifen, she can get this lifetime risk down to much lower than even 23%, which is a pretty huge reduction for her, which was originally at 46%. I don't know if we want to stop and take questions now or just go over to
I think
Kathy.
so. You've been so patient. I think it might be good to open it up to just a few questions.
Okay. Let's see.
I was
I'm going
trying to
to
go through them as I saw, but I think, forgive me, Krista, I hope I'm not saying that incorrectly. Feel
Hi,
free to.
no, of course, thank you. I thank you very much. Brilliant presentation as always. 2 questions. Is there a plan to change from BMI to waist circumference? Because now we are learning that BMI is not a good index for health. It's mostly waist circumference. And the other question is, you mentioned tamoxifen for 5 years. I think baby tamoxifen is for 3 years, so I just wanted to clarify on that. Thank you very much.
Yeah, the model that we use, the BCSC model, has been validated with BMI, so that's why we use that. My understanding is that at a population level, that on an individual level, BMI may not be the best indicator, but up for population-based studies, it's still pretty useful. That might be my misunderstanding, but the model that we use has been validated with BMI. So we can't make that change because just switching it out would not be a validated model any longer.
But one of the ways that the risk is baked in and sort of adjusted with the BCSC is we do know that the risk is different for excess body weight pre-menopause versus post-menopause. So that is not quite capturing the waist modeling that I think you ask about. But that is a discussion point that we have with participants about additional weight gain gained after menopause affects our risk differently than additional weight gain had previous that is stable. So those are all things that we can kind of get into more detail with folks who are concerned.
So what's the direction? Prior to menopause is worse or is better?
No, so it doesn't affect the risk in quite the same way. And then post-menopause, additional weight gain, which can happen as part of life changes during transition. And that hormonal discussion can get into a lot more nuance, but that can increase the risk more. So it's not quite as simple as I think a lot of the public health research, and we acknowledge that. But the model does try to sort of adjust depending on the perimenal, like the menopausal status piece.
Yeah, I think the thought is that between the pre and postmenopausal issue and BMI is that adipose tissue is the largest source of estrogen in postmenopausal women, and so that impacts. So that's tremendous. As women, the more adipose tissue, the higher the estrogen levels, and that is impacting chronic inflammation and insulin production. And that's its impact on breast cancer risk. In terms of tamoxifen, our recommendation is 5 years. And I believe that's the USPSTF recommendation as well. Any other questions before Kathy starts on her consult? Okay.
It looks like there's a hand raised from Veronica.
Sorry, I was.
Yes, I'm sorry. I guess you couldn't see it. My name is Veronica, and I have a question about a person's risk for breast cancer. Now, I have a niece. My sister was diagnosed at 35 and she died at 37, 2 years after her diagnosis. She was pregnant with my niece when she was diagnosed. Matter of fact, as soon as she had the baby, they took the breast and went downhill from there. So what I'd like to know is is my niece at higher risk for breast cancer because her mother was so young when she was diagnosed? Or does that matter?
I'm going to let Kathy deal with the genetic component here.
Right.
Okay.
So we do know that having family members with very early onset breast cancer does increase the potential that there may be a pathogenic variant identified in the genetic code that may so it's one of those things. She would be recommended to seek her own testing if she hasn't, as well as risk assessment so that she can be following appropriately for her age and personal risk factors based off of that. So it's one of those things we think about it. By the time that she's in her 20s, she should be having a conversation with her doctors about establishing breast awareness and having that conversation about what are the guidelines at that time and how has she been following.
So that's the question. While we were sitting here and I was listening to this data, I just thought about her and I just text her and asked her and made sure that she understands her risk. And I would like to, I'm going to send her the information on the wisdom study because I would like for her to be involved. Even though she's in another city, she can still do the interview and mail in the information from Chicago, correct?
hmm Yeah, as long as she's
Good.
years old or older,
How old?
30.
Yeah, she's 30.
30.
I don't know. I have to ask. I,
And
she might be coming up on 30. Now that you mention that, yeah, if she's not 30, she's close to, because
right.
it's
And
been about, okay.
but if she's younger, she also could also talk with her primary care provider and talk about a referral to meeting with a genetic counselor, regardless of if she decides to participate in wisdom or not, because it can still be beneficial
Yes,
for people who have.
exactly. She needs to know.
Yeah.
That's right.
And that's true
Okay.
for anybody on the call. Thank you, Veronica, for sharing your family story. I appreciate that. If anybody's got somebody in their family who was diagnosed very young, we would, in general, recommend them all to get testing if they have had a personal history of cancer, and if they have not been able to get testing, that they or their very close relatives, like the children that they have.
So do that apply to the boys too?
Mhm. Yeah. So it's one of those things where the risk assessment for how we manage the her son's health is going to be,
Uh-huh.
men don't have the same level of risk for breast cancer as women do. So
I
it
know.
won't change their screening in quite the same way, but it can still be important for them to know about the history, and they may still benefit from risk assessment or testing.
Okay. Thank you.
Any other question? I haven't gone through all these questions. If anybody's looked through all these questions, anything to answer right now before we move on to more genetics?
Deborah, I see a few questions in the chat. I'm not sure if you already saw these ones. One question asks if there's any connection to hematologic cancers with the mutations. That maybe will be a Kathy question.
I think that's a Kathy question.
And then there's, is tamoxifen recommended for women with CHEK2? Is that a Kathy question?
That's a CHEK2 mutation Kathy question as well.
Okay.
So for both of those, we think of, for all of you who are on the call that are wondering about the cancer history in their families, whether it's hematological cancers or blood cancers or colon cancers or prostate cancers or pancreatic cancers, any kind of cancer that's not breast cancer, we do have 29 gene panel in the Wisdom 2.0 updated panel expansion. So we are covering a lot of the genes that are associated with hereditary cancers, but we're not covering all genes. And we know that there are some families and some indications that may benefit from more comprehensive testing. Hematological cancers are something that we really aren't touching the surface on. There are a couple of genes in our panel that have been associated that are being investigated for those relationships, but it's not really covering all of that kind of history. So if someone in the study personally has a leukemia or lymphoma history, or is concerned about that history in their family, usually the affected individuals in a family are going to be one of the best people to do that kind of more comprehensive risk assessment in. And that testing could, if there's something identified, then that could give more guidance to other relatives. And then the CHEK2, if anyone's at a higher risk who wants to lower their risk of breast cancer, who doesn't have contraindications, regardless of mutation, they can consider using tamoxifen as a way of managing their risk. But it's a bigger conversation for, we always sort of discuss the option of using medications to lower our risk, but we want to make sure that we're considering each individual's other medications, their other history, and other potential contraindications.
And I see a couple other questions in the chat real quickly that I can deal with. One is this patient, this example that I gave. She had come to us. She had already had screening, but because of the polygenic risk score, that was really the new information that really upped her risk. She had been getting annual mammograms, so it was the inclusion of the MRI that was new that we were able to provide for her. And again, what really topped out her score, she already had atypia, which was increasing her risk substantially, but it really was the inclusion of the polygenic risk that made her risk go significantly higher. She hadn't stopped. She had already started screening. We just added more to it. In terms of the gadolinium and the risk with that, there's a question about the risk of that with multiple MRIs. If you start at age 50, are you suggesting at least 2 decades of MRIs? A couple things. One is the algorithm that I went through was kind of an overview. There's much more branching logic in there as well. And so, for example, someone who is at elevated risk, and when they turn 65, we then look at density. If they have low density, meaning a density of category 1 or 2 or A or B, depending on how you interpret it, we then would drop the MRI at age 65. If they have a high density, we then look to lifetime risk. So there's a lot of branching logic that kind of dials it down a little bit. Also, if they take, for example, the tamoxifen, it's certainly possible to get their risk below that elevated. Maybe not. The example I gave was pretty extreme with a 5-year risk of 19%. That's, again, an extreme example. Most of our people are closer to 6% that we're recommending the breast MRIs. So if they take the tamoxifen, they can, within 2 years, get those numbers down and hopefully lower their density as well, which is an added benefit of the tamoxifen. So that, yeah. Those are all the questions I see. Your risk does get higher as you get older. Risk was kind of the number one, or age is the number one, the first variable that went into that BCSC model. So it's true that increased age, increased risk, although that is a bit deceiving in that the type of breast cancer typically changes as women get older. As all the people with MD after their name know, nothing is all or nothing in medicine, but your average breast cancer diagnosed at age 40 is typically much more invasive, fast growing, and than the typical breast cancer someone gets when they're age 80. So as an overall, yes, risk does increase with age, but the type of breast cancer usually changes. There are some side effects with tamoxifen. The most notable is hot flashes. It's very much minimized, though. We are advocating low-dose tamoxifen, which is 3/4, which is like the original dose was 20 milligrams. Low-dose tamoxifen, which is also fondly called baby tam or mini tam, is only 5 milligrams. It very much reduces side effects. But with the original 20 milligrams, the most common side effect is hot flashes. And side effects also do increase with age. So if we can get somebody on the younger side who's at higher risk of a more aggressive cancer and get them on tamoxifen, it's amazing. It's a really good thing.
And it can lower their density, which makes mammograms more effective for screening and identifying. So yeah, it has multiple benefits all baked into one.
If someone wants to speak up, if I'm missing your question. Oh, how does one get health insurance to cover an MRI? If we have you in that group where we're recommending an MRI, we also provide a letter of medical necessity for your provider to submit to insurance company to help with coverage. And those have been doing a really good job getting coverage for our participants. Does anybody like to speak up with a question before Kathy moves on? Kathy, you're on.
All right. And all right. Oh, where it hit reset. So, okay. So one of the big things I just like to focus on with folks is I think all of you are thinking about that family history. There's been a lot of fantastic questions. I really appreciate you all thinking about it. Um, and if you're not sure about the family history in your family, sometimes it can be worth having another conversation and asking about, because cancer history can change over time. And we talk about the health and lifestyle risk factors that impact risk, but we also know our genetics can make a big impact as well. And generally, when I meet with participants, I'm talking about people who have specific known gene mutations or pathogenic variants in their DNA that are changing how their body protects against cancer. And there are different specific guidelines. We don't need to get into all these details. I know we want to make sure there are plenty of time for questions, but generally we talk about what specific guidelines or recommendations are recommended for the level of risk that is identified from each participant's genetic result, and make sure that they and their providers are on the same page about what screening is being recommended and what options they have that they can pursue to manage those risks. We generally think about sort of walking through the specific mutations and family history. And I mentioned, even for those who test negative, there may still be relatives in the family, especially those who many of you may have concerns about, who had personal history, who may have a variant or other risk factor that you did not test positive for. So even if someone has tested negative, we encourage people to talk with the family about what your results were, and encourage those who have not sought genetic testing for their own cancer history to think about potentially doing updated testing. Because even if they had testing, back in 2010 and it was negative, it may not have been what we think of as modern or comprehensive testing for what we now know today, because genetic testing technology has improved a lot. So we just encourage folks, I have those conversations, and encourage people to share the information about the history. And this is one example of a specific, one of the many genes that we have consultations for. But there are different cancers. Obviously, as a breast focus study, we talk about the breast focus, but some of these have other cancer risk factors, and we talk about those recommendations and encourage people to get connected with genetic counseling. And both within the study and outside of the study, we encourage people to talk to their relatives and to share this information and their results with other affected and non-affected family members, because it can change how they might screen. And okay, I see some great questions about talking about prostate cancer risk and male breast cancer risk. I agree. I think there's lots that we're obviously just a breast focused study, but we encourage all of you to talk with family members and loved ones about cancer history, even beyond just breast cancer history, because there may be other loved ones who may benefit from doing their own risk assessment or more comprehensive discussions. And that actually the people that I talk to in that blue little pie are a very small portion of cancers, who only about 10% of cancers are actually thought to be clearly associated with mutations that are identifiable in our DNA. And we know many, many more people fall into that darker gray category, where there seems to be a family pattern, but we don't really know why some families are being more affected. And we know that there is some lifestyle and environmental exposure related risk factors, but there also may be genes that haven't been discovered, or other risk assessment that can potentially be done in future that may find the answers for some of these families that don't have a known gene mutation now. And some people may still benefit from additional screening regardless of their gene mutation. So I want to be mindful of time and try and give folks time to have their questions answered. But generally, we, as part of the consultations, we review all this in more detail and talk about the results and all those specific screening recommendations and considerations that are unique to the specific gene involved, and make sure that they and their doctors have a good plan in place for how best to manage their breast cancer screening. And it looked like there was I had thought that I saw a raised hand, but now I'm not seeing things. Um, but in general, we go through that family history and the different risk factors and mutations in more detail with individuals and try and make sure people are connected with the resources and screenings that they need based off of those specific risk factors. So we encourage you all. We now are doing a partnership with Color. They're also helping to offer genetic counseling in association with us as well. And that's been a great addition to the 2.0 version of the study that has helped with increasing access and availability for consultations. So if there are any of you who have been wanting to have a consult but haven't because of limited availability or timing, that has broadened up a little bit. And the Wisdom Study partnership with Color is continuing. So if any of you have additional questions, or if when you talk with your loved ones about our recommendation to find out about family history, that you have the opportunity to request consultation with them as part of the study. And with either Deborah or myself or any other breast health specialists with the study.
Kathy, I have a logistic question for you to answer. If you're in the study and you have a breast health consult, is there a report that you can take home with you or send to your doctor? Or how does someone, collect this information and be able to do something actionable with it outside of Wisdom?
Yeah, so we've got the screening assignment letter and the consultation summary, as well as the genetic testing result. In outside of the participants who test positive for gene mutations, those that are talking with Deborah about the higher risk, they also get a breast health decisions tool, which is a step-by-step sort of breakdown of the risk factors and numbers that go into their risk assessment. And that we encourage participants to print out their risk summaries and take that in with their doctors so that their local providers can be in the loop about the recommendations too. And if there's ever questions that their providers have, they're encouraged to reach out to the study. We deal with provider questions frequently, so we're happy to help if there's ever uncertainty.
Fantastic. That was actually my next question for you is what if providers are unfamiliar with the guidance you're giving or are not in support of the guidance you're giving? It sounds like you're willing to chat with the providers directly.
Yeah, and we also are a pragmatic screening study. So we understand that sometimes people enroll in breast cancer focused studies because they're very concerned about their risks or they have a very specific plan in mind that they want to follow. And if a participant or the providers have a different plan than what we're recommending, that is not an exclusion from participating in this study. We just encourage folks to share the recommendations with their providers, and we're happy to meet with you and try and clarify and provide any education that we can about why we might be looking at different risk factors or have slightly different numbers, and be able to try and help support access whatever level of screening is indicated from our risk assessments.
Awesome. Thank you so much. And thank you, Kathy and Deborah. I think, let's see, is there one more question? Oh, we have like a few more minutes left, and I see a question from Valentina that asks if you can briefly explain how tamoxifen works, and then a question from Diane, who asked if you can talk about Wisdom's findings that many women who got genetic testing on the study and found out that they had a mutation had not reported a family history of breast cancer.
I can quickly take the tamoxifen one.
Okay.
I'll save the genetics for Kathy. Um, tamoxifen, actually, there are two medications that we discuss with participants that belong to the same category. They're called selective estrogen receptor modulators, or SERMs. And what they do is they block estrogen, they bind to estrogen receptors. And what's selective about it is how that estrogen receptor responds. So tamoxifen binds to an estrogen receptor in the breast, and it acts like a wall, and it doesn't allow circulating estrogen to bind to that. So it's decreasing the risk of estrogen receptor positive breast cancers, which is the vast majority of breast cancers. Tamoxifen also binds to, for example, estrogen receptors in your bone, and those estrogen receptors interpret it as estrogen, and bone likes estrogen. So tamoxifen and raloxifene are also good for bone. So that's how tamoxifen reduces the risk of breast cancer. It also reduces, and that's the reason we recommend it. As an extra additional thing is it can also decrease breast density. So that's kind of just an extra benefit. But that's how it's decreasing the risk of breast cancer. All right, Kathy, you're on for the genetics.
So, a couple of great questions. So, sorry, I'm looking at so many of the questions in the chat too. There had been questions about how best to follow for different mutations. Okay.
There's the wisdom findings about women who got genetic testing after the study and found out they had a mutation, yet they didn't have a family history of breast
Yeah.
cancer.
So that is one of the findings that we had with the study. It's one of the more surprising outcomes, but I think a lot of genetic counselors who have been in the field have been recognizing there's a lot more individuals who have pathogenic mutations than what previous very restrictive guidelines would have flagged or identified. And that was because a lot of research that originally was only testing people who met very narrow criteria or very narrow definitions of risk were eligible or able to get testing in previous research. And I think that's something that more public health studies are finding replications of this, where there's more people who don't have the same family history as what we might expect with some of these genes. And there's a lot of things that can potentially help explain that are a little more complicated than what we have for the scope of this meeting. But I think it's just invaluable that we're finding out about risk factors that people can use to make their own screenings more informed. And we encourage folks, regardless of the family history, to be using this information to try and inform their screening and manage their risk as we learn more about all of these different mutations.
See one more question there about weight, maintaining a healthy weight, and if it directly impacts breast cancer risk. The weight and exercise question are related indirectly. They both are thought to, I mean, as I think I explained before, adipose tissue is a big increased adipose tissue increases estrogen levels. That is a big site for estrogen production, primarily in postmenopausal women. So the more adipose tissue there is, the higher circulating estrogen levels there are. It's thought that high estrogen level increases both inflammation and chronic inflammation, and it also and it increases insulin levels. Both of those things are thought to increase on a pathologic level some breast cancer growth. So that's kind of the mechanism of both of those things. That the exercise is directly impacting insulin levels. Stress definitely has. We do not include stress. That is. A lot of people ask me about a lot of those risk reducing strategies, specifically the lifestyle factors, and we do limit it to a few. That being, there's a lot of dietary components that obviously have an impact. You can open up any journal on any day and see some new dietary impact on breast cancer risk. But we can't, that data is not, as with stress, it's not to the level where we can quantitate it. I'm sorry, I used adipose tissue. Yes, I do mean fat. Body fat is adipose tissue. So there's a lot of things out there, but they've not been reproduced and validated to a level that we can actually make recommendations on a quantitative level. And that is why we don't specifically talk about those things. We can't apply it to your lifetime risk and say, if you do X, your risk will go down to Y. So that by limiting our lifestyle factors, we're not saying that those are the end all there and that nothing else impacts risk. Those are just the things we can quantitate, really. Science is fluid.
So I know we're at the top of the hour, and I just want to thank everyone for joining and for these wonderful questions. Thank you to Kathy and Deborah for all of your effort in creating these really wonderful, extensive educational slides. I know that you put a lot of time into it, and we really appreciate it. This has been recorded, so we're going to put this on our YouTube channel, and we can all rewatch it and continue to learn after it. And if anyone has any questions, I'm going to put the YouTube link in the chat so people can access it. And if anyone has any questions, you can also email us your questions if you need any additional information or more clarity. And also, we had that little pop-up screen asking if you're interested in other topics for us to go into on a community forum. Let us know. We've done a few forums in the past on some of these topics. I just looked quickly at the long list of topics. We've done them on polygenic risk score. We did them on risk reduction or prevention measures like that you can control, like exercise, nutrition, and alcohol consumption. And yeah, we've got a lot of good content out there. So thanks again. We hope that everyone has a wonderful, next coming month until we see you again. February 23rd, I think, is our next forum. It's Monday. We usually have these the last